Good evening, everyone. This is Dr. Richa. I'm a physiotherapist, and today we'll be doing a live on what is AVN, avascular necrosis. And let me introduce you all to the doctor who's going to be answering all the questions. We have with us Dr. Naveen Kumar LV. He's from Bangalore. So Dr. Naveen Kumar LV has completed his MBBS from BLDEA's Medical College from Bijapur and done MS Ortho from KMC Mangalore, which is Manipal University, with over 21 years of vast experience in diverse fields of shoulder, knee, and ankle arthroscopy, hip and knee arthroplasty, and trauma. Dr. Naveen is prestigious John Charnley Gold Medalist at Wrightington Hospital, UK, topper at DIB SICOT Italy, and Best Trainee Awardee from BIOS UK. He achieved the distinction at FEBOT Portugal and FRCS Orth 1 from England. He has achieved 10 qualifications to his credit so far. He has completed several fellowships in UK and Germany in arthroplasty and arthroscopic surgeries and has presented his papers on various podiums across the globe. He has been operating at Apollo Spectra Hospital, Narayan Hospital, and Manipal Hospital as a senior visiting consultant, and has set up his consulting chambers in HSR Layout and Koromangala in Bangalore. Okay, sir. So was my introduction correct?
Of course. Thank you very much, Richard. Thanks for welcoming me. Thank you.
Okay. So should we start with the questions?
Absolutely, we can.
Okay. So we'll be talking about avascular necrosis. So the first question is obviously, what is avascular necrosis? If we try to explain it in simpler terms.
Sure. So this is one condition which has been affecting people who are typically in the age group between 20 to 45 to 50 max to max. This is the common age group in which we see this problem. So people often hear this word and get puzzled about what it means. So the main problem here we are talking about is regarding the hips, but we do see avascular necrosis in different joints as well, different bones as well, but very commonly in the hip joint. So if we take a look at the problem size, in India, we get around 2 to 2.5 lakh people with this problem every year. That means that a city of the size of Bangalore, for example, will see around 1,500 patients who have newly got diagnosed to be having avascular necrosis of the hip.
Yeah.
However, the numbers are increasing in the last few years. That's another thing which we'll come to. But this is avascular necrosis. Let's try to understand this terminology first. So nowadays we use a newer term called osteonecrosis, but it all means the same pretty much. So basically the hip joint has got a special blood supply. Hip is a ball and a socket kind of joint. So where the ball is something which has got a blood supply which comes in a reverse way. So the blood supply comes from a ring of blood vessels around the neck of the ball, and then it comes to the head where we have got a literally like a football with underlying something supporting that area. The bone will be supporting that area. So this area, if it loses its blood supply, that's right, what is called avascularity. And when it loses its blood supply, it can't sustain itself, because bone is a living tissue as well. A lot of people don't realize that, but bone does have that supply, and it is very important for the bone to keep recovering and regenerating itself. So when that bone is not holding well enough, when it's not supporting well enough, then the ball starts collapsing. So that is what is called avascularity, where the blood supply is not there, because of which the bone starts dying. This is called avascular necrosis. That's the condition we are talking about.
Okay, so it was very well explained in simpler language. So moving on, are there any specific risk factors or population that is likely to develop AVN?
Absolutely. So although there is a sizable number of people where we don't or can't find a specific reason for why they developed it, and we call that as idiopathic or no reason kind of
Yeah.
group of people. That forms around 30% of people. But in vast majority, around 70% of people, there we often will be able to identify a reason. In good old days, which I'm talking about pre-COVID era, before 2020, it used to be common reasons used to be overuse of steroids or alcoholism or smoking, or people with rarer diseases, sometimes autoimmune diseases, or accidents, which used to be a common thing where dislocation of the hip post that the bone loses its blood circulation. These are the kind of common reasons we used to come across. But to be honest, we are seeing more and more number of people with avascular necrosis since the COVID started. So in people in whom steroids have been used for treating COVID, in those people as well, the risk is higher. And even people who had just had COVID but without any steroids, even in those people, we see that the numbers have increased. So this is one thing which has become probably the number one cause for AVN, at least in the last 2-3 years.
Okay, so if you have had any COVID history, you are likely to get affected with AVN. Just being mindful of that is a new thing.
Not all of them, but especially if they develop any pain around the hip, which is more than a week or so, and which is unexplainable by any simple injuries or anything, and then better to get an opinion or get it checked at least for the basic.
Exactly. Yeah. Okay. So, like you said, so are there any investigative methods that confirm AVN diagnosis once you feel hip pain for AVN specifically?
Of course, yes. So when we say the word AVN, a lot of times the diagnosis can get delayed because people are not suspecting for this particular condition.
Right.
So that is one of the things which we commonly see, unfortunately, even today. In fact, for post-COVID era, it would be a better thing to have a heightened suspicion and do basic investigations at least, which includes an X-ray, which will give the information often. However, X-ray is not always conclusive of this. So especially if the person is having restriction in the rotational movements of the hip, whomever doctor or physiotherapist who is examining the patient, better to have a heightened suspicion about this and escalate that. And getting an MRI scan is not a wrong thing for these things, because that can at least clearly tell us or give us an information as to whether any changes are there in the hip joint or not, because that can be a very conclusive kind of test which gives us it has got a sensitivity of 99%, so that will help us in ruling out the things or ruling in the things at an early stage.
Okay, great. So yes, if someone is suffering from hip pain for a long time, it is better to go for something as accurate as MRI. Just getting an opinion from your orthopedician and not overlooking it.
Absolutely.
Okay. So which parts or joints of body can be affected by the disease? The most common site, like you said, was hip. So elaborating that.
Yes. So AVN of the hips is one of the common things what we see out of all the others. However, other common sites where we see is the weight-bearing joints, particularly, including the inner side of the knee, which we call it as distal femur, or the lower part of the thigh bone, where that is one region. We do see it in a bone called talus, which is in the ankle area. These are all things which happen because of the peculiar blood supply for these areas, which is why they are at risk of developing this kind of problem. Another common area is shoulder. These are the common ones, and there are some less common ones which can happen in the wrist joint, bones, and all the rest of things.
Right. Okay.
Yes.
So now that it is cleared, can you also, in short, let us know about stages, classification, and its importance? Since many patients, when they get an MRI scan, they see that something is mentioned, some percentage is mentioned, something stage is mentioned, but they don't understand it. So
correct. So in simple words, if I may put it in a nutshell, see, there are quite a few different classifications which get used. I mean, there is a good old Fickat-Arlet classification, then came the Steinberg, then there is a classification called Arcos. So, I mean, all of these classifications, the main reason why we are doing this is to understand how much the problem has progressed, because this is a progressive disease. In the sense, we may sometimes see it in the very early stage where there are very minimal changes, where there is a bit of bone changes, where there is some amount of bone death which is happening, but nothing else. Or sometimes we may see it in the next stage, where there is a kind of geographical area, where there is a kind of distribution of the area, where there is bone loss. Or the next stage is something where, which is a decisive factor, where there is something called crescent sign, where we will start seeing a kind of double borders along the ball, actually along the lining of the ball. So if we are seeing that kind of double line sign or that kind of changes, that tells us that the bone is dying in that area and it is ready to start collapsing further, and the ball is going to deflate. That's what it's going to tell us. So if the ball deflates, it becomes like a mushroom. And once that happens, the congruity of the ball and the socket is lost and it becomes arthritic. That's a stage 4, we call it. So the things which we mainly are talking about here is to differentiate between the stage 2 and stage 3, in the sense just the pre-collapse state and the collapse state. That's the kind of borderline which we are mainly trying to draw with any of these classifications. The reason being, the treatments which we talk about are different if they are in the early stages, and the treatments would be different if they are in the later stages. That's the main reason. Rather than getting into a specific which classification is better or worse, just this kind of watershed line, if we understand that part, that is one thing which we are mainly looking at as a simple differentiating factor where the outcomes can be different.
Right. So based, like you wanted to say, is the treatment can differ based on stages, and that is how it is important.
Absolutely.
Right.
Absolutely.
Yeah. Okay. So the next question is, obviously, if someone is diagnosed with AVN, how can it be treated? And can AVN be treated without surgery, which is one of the most common patient inquiries that we get?
Correct. Exactly. So this is one condition in orthopedics which sometimes can be difficult for patients to understand. The reason being because the kind of terminologies which get used can be difficult to understand. And second thing is, people sometimes find it hard to grasp that this is something which can go on gradually worsening and become something bad over there. That is something which is difficult for patients to understand. But unfortunately, almost 97-98% of these conditions progress, in the sense over a period of time they will gradually increase. I'm not saying that it will increase within a week or 2 weeks, but over a period of, if we consider 6 months to 1 year, it can progress from anywhere from stage 1 to stage 3, stage 4, if we don't do anything about it. In some people it may take longer than that as well, but usually around 1 to 2 years of time frame for the things to get from good to worse. That's the kind of thing we are talking about. So for patients to understand this, it becomes difficult, especially in the earlier stages. And there is enough things on the internet which can confuse people as well. That is another problem which we commonly face.
Right.
But to be honest, we have to be pragmatic about what works and what is evidence-based kind of treatment. So some lucky 2 or 3% people may not progress at all, but majority of them will gradually deteriorate, regardless of whether they are 25-year-old or whether they are 45-year-old. So the thing is, if it is caught at the early stages, especially if it is in the stage 1 and stage 2 kind of things, yes, non-surgical treatment, in the sense just the medications, can be of some help in minimizing the progress of, or at least halting the progress of the disease. Like there are medications which are called bisphosphonates, which are to improve the bone strength, and there are medications like blood thinning medications like ecosprin and all the stuff, which we do, but they don't cure the problem. That's one thing people need to understand. The problem is, many times when this kind of prescription or medication is given, people would assume that this is going to cure it. But unfortunately, that's not the case. So that's one thing which needs to be clear when doctors explain that as well. And second thing is regarding the kind of treatments which we talk about. So if we talk about what is the treatment when we go to stage 4, then it becomes easier to work our way backwards, because that is one thing which we need to understand. So if it comes to the point where it has reached the stage 4, which is arthritis of the joint, then to be honest, apart from replacement of the joint, there is no other viable alternative for that problem. But there are two angles to that, or three. One is replacement is a much bigger surgery. So one thing. Second is replacement has a life. So replacement can last for 15 to 20 years on an average. Suppose if you are doing a replacement for a 25 years, then his replacement will last for only 15-20 years. Then again, he will be ready for another revision and another revision. So in his lifetime, we'll end up having 4-5 revision surgeries, which become bigger and bigger surgeries each time. So from that perspective, replacement is something which is a last resort. But if there is no other viable alternative, and if the person is really struggling to walk around, even at young age, I am not saying that it's a wrong treatment. But for the people with the stage 4 kind of changes, where already they have got bad arthritis, the head has mushroomed and the joint has literally been destroyed. So in that age group, or in that group of patients, that's a sensible thing.
Right.
So now we get the people who are in the early stages, especially in the stage 1 and stage 2. That is the time when people will be questioning as to, should we really do something or should we wait and see? The problem with waiting is you wouldn't know whether you will take 3 months or 6 months or 1 year to go to stage 3, stage 4. And if you miss the boat, you can't come back again after.
Right.
So whatever we do has to be done at that point of time. So when we say at that point of time, what has to be done in the sense, in the good old days, 80s and 90s, we didn't have much of technology then. So we used to do what we call as core decompression, which was not a bad surgery. That is something with the whole idea of that surgery was to decompress the pressure there, because this AVN, avascular necrosis, happens because of increased pressure in the capsule of the hip, because of which the circulation has been cut off. So once we do the drilling of that small tunnel into the wall, so the blood circulation is to get restored. So that was to have a decent improvement in the condition in about 60 to 70% people, which used to last for around 15-20 years. But not in everyone. And even in those it had improved, there used to be some pain and problems which used to stay. So this is what used to be the case in 80s and 90s. Then in 2000s, there were newer things which came in. There was one thing called BMAC which came in, and now from 2010 onwards or so, we are seeing something which is called stem cell therapy. All of these are newer technologies, which are the most advanced technologies which are being used worldwide. So in terms of technique wise, this is not a complicated technique. It's operation wise, it's not a big operation. What people need to do there is, they will have a 2-stage of procedure when we do these things, where in the first stage, we take the samples from the bone marrow, we send it to the lab. It's a literally 15-minute procedure. And once the cells are grown, so the cells are artificially grown. The reason why we do this is because, see, when we do the core decompression, although we have cleared up we have made the blood circulation to restart. But what about the dead cells? How are we going to take them out? How are we going to get the ball filled up again? That's the question. So for that, the stem cells fit in neatly, where we still do the core decompression. And these stem cells, what we are talking about, these are basically the kind of specific cells which are called osteoblasts. So in the lab, these cells get separated as a separate line of things, and they get grown in millions. So we get around 50 million of them grown, 50 million cells, and they are sent in a form of injection to us. And what we do is we still do the core decompression. We take out all the dead bone by scooping it around, and then we inject the stem cells. So by doing that, we have reduced the pressure there so that the blood circulation can restart. And with the new cells, it can form the new bone, which is what is going to support the ball again, so that the whole thing can return back to the So the second time when they come, this procedure will take about an hour or so, even if you are doing it from both the sides. That's the kind of procedure we are talking about. So from outside, it is hardly 2-centimeter cut, which the patients will see. There is nothing which is a big cut or big surgery or nothing like that. But although it's a procedure wise, it's not a major procedure because of the kind of things which we need to do. It's a bit expensive procedure, but it is worth considering because this is something which can actually help in getting the best possible outcome with the latest technology which is available in today's day and age. So although BMAC is something which people do consider, but in that one, although we are separating the cells, they are not completely the osteoblasts, and what line of cells we have separated, we wouldn't know. So for that reason, I would rather suggest that we do this kind of technology, which is the best possible one available. But there is another angle to it, because we do get people who come in stage 3 sometimes.
Right.
That is the one which becomes a bit difficult, because they are the people who may not respond that well to our even the cold decompression and stem cell, but they are not there yet to go and have a replacement. So this category becomes a bit difficult. I mean, ideally, I would like to capture all my patients in the stage 1, stage 2, but in practical world, it doesn't always happen.
Yeah.
But even in stage 3, a lot of times we have seen decent outcomes where the pain has improved, the bone has reformed. In about 60 to 70% patients, at least, we have seen good results. But we can't assure the results like what we do for the stage 1, stage 2 patients. But still, if we consider what is the alternative, when there is no other alternative, it is still worth considering, even in stage 3 patients, according to me.
Right. So because they can save their hips, they can use their
Exactly.
natural joint and
Yes,
not undergo replacement.
absolutely.
And yeah, and it is also, like you said, a minimally invasive procedure. There's
Yes,
no foreign body that is being introduced. So that way also it is better.
exactly. And also, once we do the hip replacement, there will be a lot of limitations which come into place in terms of low chairs, they can't sit, Indian toilets, they can't go on. So all of those things will come into place. So replacement comes with its own baggages. So
Right.
those things are not there. If the regrow, if the stem cell therapy works, then there is no such baggage with that.
Yeah. Right. Okay. So no movement restrictions if the
Correct.
patient undergoes bone cell therapy.
Correct.
Okay. So you have explained the treatment quite well, sir. So the last question would be, if I'm a patient or if there's a patient, what should the patient do if they are diagnosed with AVN just recently? So,
Yeah. So, see, this is a kind of confusing kind of terminology, and it's a whole world suddenly comes into place, because these are young patients whom I see. For them and families, it will be heartbreaking, which is all we can understand. But the thing is, in terms of seeking the right kind of help early would make sense, and trying different kind of alternative therapies. I'm not against alternative therapies, but there are places and times when they can work. But unfortunately, unfortunately, regarding the AVN hip, there is no such viable alternative therapy which we have come across or seen, which can be evidence-based kind of treatment is unfortunately not there. So from that perspective, rather than wasting time and coming late for the treatments, it would be best to see an orthopedic surgeon, get the diagnosis done quickly, and then get the act together quickly in terms of if it is showing stage 1, stage 2, not to waste time and faff around, better to seek the help early and get the right kind of help early, so that they can save their hips and their livelihoods and their lifestyle as well.
right, right. Okay, thank you, sir. That was very helpful and informative. Hopefully, this will reach out to the people and provide them some clarity when they are very confused. And the right thing to do would be first get a diagnosis and obviously research for your options, but go for something that is evidence-based and will help you in long run. So, thank you, sir, for joining us and giving us your precious time.
Thank you very
Um,
much.
yeah. Would you like to say something before ending the session?
Sure. This is a message for patients with AVN hip. See, this is something which I see patients on a regular basis, and people are worried. People are worried about everything regarding their lives, which is understandable completely. But there is a treatment, there is a right, if it is done in the right way, the right kind of treatment, you can absolutely achieve the kind of life back what you were leading before. But act in the right time, and please don't waste precious time and delay the things. Thank you.
Thank you, sir.
Thank you.
Have a great day, and everyone else who's watching this, hopefully this was helpful. So thank you very much. We'll be ending our session here. Thank you.